So this will be the bone fracture Xmind for the entire hand therapy, or the umbrella hand therapy project. So it will start off, I'll be skipping through a lot of things. There's a lot of information that I put onto this, but I will just hit on the main topics. Basically, the structure and physiology of the bone initially starts it, and there's two types of bone. There's cancellous, which is trabecular, or even more layman would be spongy bone, and then cortical, or more layman, is compact bone. Trabecular is on the end of long bones, also on inside flat bones like the vertebrae, um, and within the carpal bones. Compact bone is usually on the outside, is always on the outside, and that is in the shaft of long bones. So bone formation mechanisms, I will also talk about this later, but the bone formation mechanisms are intramembranous or primary bone formation, and that's in which there is no cartilaginous callus formation. It just transitions into bone again. Secondary, which is or endochondral bone formation, is the one that will have the longer phases, and those will be going into more depth later. But basically, there's a callus formation, and then there will be bone that replaces that callus, cartilaginous callus. Fracture etiologies, they include trauma, microfractures, and pathological fractures. There's more information about each one that you can go into later. And pathological fractures usually are cause the weakening of the bone, and then microfractures and then trauma will result in the inevitable fracture. There are the fracture types. There is transverse. Every one of these is going to have information also. Spiral, oblique, comminuted, impact, crush, / compression, torsion, or torus, or buckle, green stick, avulsion, and dislocation fractures. Nature of fractures include closed, in which the skin remains intact, no bone punctures the skin, and open, where in which the bone fragments puncture the skin. There's the fracture healing phases, and I will start out by saying that fracture healing patterns, bone is one of the few tissues that will heal without fibrous scar tissue formation, which is great. And primary fracture healing, which goes back to the bone formation information, which is it's just a direct reestablishment of the bony cortex. Usually occurs with simple fractures that are internally fixated. So without internal fixation, usually it ends up being secondary fracture healing, because it requires very, very small gaps, millimeter gap or so, and absolute stability, no motion at all within the area. Secondary, and there's more information here too. Secondary bone formation or fracture healing is basically endochondral bone formation. There's that bony callus that occurs, and that will go into more depth actually in the phases of healing. It only requires relative stability, and examples of fixation for that result in secondary fracture healing are splints, casts, certain intermedullary fixation devices, and external fixation, which is used in complex fracture patterns. The inflammatory phase includes, basically, it's the hematoma formation, and then there's a granular tissue formation, which initiates the soft callus formation. So the hematoma forms, there's bleeding in the area, then there's the pro-inflammatory mediator drives the other cells that are the macrophages to the area to basically destroy the dying cell areas of the bone, and also that it draws the stem cells, these angioblasts, chondroblasts, fibroblasts, and osteoblasts to come, and that's just the growth factors It's not much necessary. No, um, those start to carry out the regeneration phase after the macrophages have destroyed the already dead area. And then a granular tissue formation occurs from that. And then a primitive soft callus forms, which stabilizes the fracture somewhat. Then the repair phase begins basically with the granulation tissue formation, so there's that overlap. And that lasts, the soft callus lasts day 4 roughly to week 3, and then roughly the hard callus is week 2 through week 6 for the upper extremity, which is what we'll be talking about. The primary soft callus forms initially, and that can occur via both intramembranous or endochondral bone formation, but there will be no cartilage in the intramembranous formation. And there's a differentiation of these cells, the stem cells, that go into the proximal end begins the bone the proximal end of the fracture line, basically the middle of the fracture. There will be the chondrocytes, which form the hyaline cartilage, and that helps stabilize the fracture. And then at the distal ends, basically out the ends of the bone fragment areas, they become osteoblasts and synthesize the intramembranous woven bone. And then the hard callus forms in this after the entirety of the soft callus forms. So in which the woven bone gradually replaces the hyaline cartilage via endochondral ossification. Basically, the cartilage or the hyaline cartilage becomes woven bone. That greatly increases the stability of the fracture. And the third phase is the remodeling phase. It lasts 6 weeks to 3 to 5 years, and that's where the lamellular or trabecular bone replaces the woven bone to restore most of the original bone strength. And then the compact bone replaces the trabecular bone, and that's about the entirety of it. And then a clinical relevance to fracture healing, basically children heal the quickest 4 to 6 weeks, adolescents 6 to 8, adults about 10 to 18. And in the inflammatory and repair phases, that is where there is the immobilization, and we want to first we reduce the bony malalignment, and then there's either surgery or casting involved. And then this would be a example plan of care during immobilization. You can look at that later. During the remodeling phase, there is a bony union. There's 2 types of bony unions. There's a stage of clinical union, in which basically the fracture site no longer moves or has any excess or any pain, but there is a fracture line still apparent, but there's evidence of bony callus. Usually at that stage is where the immobilization no longer is required and the cast comes off. And the bony union that is radiologically union is in which the bone is considered radiologically healed. There is no fracture line anymore. Usually that's at the very end, in which the mature lamellar bone is formed. And then a typical intervention for the remodeling phase, in which there's the post-immobilization and the cast removal, and you can go into and look at this. And so now we go to the common, I'm going to go over 2 common fractures of the upper extremity, and the first one is a common elbow fracture, which I will go over the fracture of the radial head and neck. And I have my references all listed right here, and you can look at them too. They'll pop up. They're uploaded on this Xmind. The etiology and diagnosis. Etiology is basically a fall on the outstretched arm or hand is fouche, the elbow extended and the forearm pronated. And diagnosis, you can go over looking at that. Usually it's a report on the fall. Difficulty of flexion and extension, difficulty pronation, tenderness and palpation at the radial head, and fat pad sign on the radiographic, basically, and an X-ray fat pad sign. There's classifications. I won't go extremely into these in this recording. And so now there's the treatments. The non-operative treatment includes a conservative treatment is usually for a type 1 radial head fracture. And you can go over this later on. But basically, it's a sling immobilization, closed reduction initially. Mobilization, posterior splint for the days in which to add comfort to the patient. There's also the cryotherapy, use of NSAIDs to reduce inflammation, and which is pain medications. And operative treatment, it's usually a treatment that indicated for type 2 through type 4 fractures. And you can go over to this later on. And there's also the information about what you would do during an evaluation, initial evaluation, which occurs usually after immobilization, during the post-immobilization phase. Non-operative rehab, I have protocols that I made for each one of these. I put together, which all have each one of the goals for these different phases of the rehab process. The early phase for this one has about 4 phases, and each one of them has goals of that phase and the interventions used during that phase. And I'm not going to go into that in the video, but those can be looked at later. And then also have an operative rehab protocol that has all the same thing and the time periods. And then I have also the second one is a common distal fracture of the radius, or a Colles fracture, more commonly called. Also have my references here. The etiology. It's also a FOOSH, forearm pronated. And there are also coupled injuries, as you can see. They also have the non-operative treatments, which good alignment of bony fracture, plaster cast would be put on there. Basically, immobilization will occur roughly for 5 to 6 weeks. And now I go to operative treatment. Operative treatment usually is an open reduction with internal fixation, or a closed reduction with external bridging fixation. And then there's some other information here about that. Evaluation, also have information about what to look at during the evaluation, the various different points like gait locomotion, functional mobility, circulation, joint integrity, muscle strength, observations to look at, ranges of motion to take, self-care ideals to look at, sensory testing, and special tests also, like DASH and all of that. And that's also for the elbow fracture too. So now I go into the rehab protocols. I also created protocols for this one. And it has all the same features as the first type of fracture I was talking about. And you can look at all those later on. And then I also have a post-operative rehab for that with time periods and goals and interventions. Alright, I appreciate you watching this video, and hopefully you'll go in more depth by looking at this Xmind in your own time. Thank you. This is Andrew Napolitano, and I created this portion of the hand therapy project for bone fracture.